Hello, everyone. My name is Athari Salmeen. I'm one of the chairperson. I am more than happy and honored to welcome all the renewed guests and delegates in the fourth chapter of MENASO Education Academy Cerebrovascular Grand Round Series 2023, organized by MENA STROKE Organization, Middle East and North Africa Stroke Organization, which is a region-wide non-profitable organization committed to a vision to reduce the overall stroke burden in the MENA region. MENASO Education Academy Cerebrovascular Grand Round Series 2023 is endorsed by World Stroke Organization, Pan-Arab Union of Neurological Societies, Sheikh Khalifa Stroke Institute, Johns Hopkins Medicine, and the American Stroke Association. We had fantastic years in 2021 and 2022 with the Grand Round Series that discussed various topics in the comprehensive education about stroke, its treatment, and management. I thank all the committees and delegates for their outstanding effort. The 24 webinars conducted so far in the Grand Round Series in 21 and 22 have been fruitful and rich with the presence of 50 scientific committee members, 65 MENA region speakers, 30 international speakers, and more than 30,000 participants from 85 countries around the world. Today's focus will be on updates from the ISC 2023, as well as cerebrovascular thrombosis in 2023. After which we'll have our question and answer sessions, hopefully. Dr. Nuran, if you want to go ahead and introduce the first speaker.
Okay, sure. So hi, good evening, good morning, everyone, wherever you are. So the first topic is going to be about the update from IC 2023, which will be presented by Dr. Pooja Khatri. And she's a professor of neurology at University of Cincinnati. She's the director of the Vascular Neurology Division and the director of the National Coordinating Center of NIH Stroke Net. And she has a board experience in therapeutic development from conception to post-marketing phases. Her specific expertise include acute stroke, secondary prevention, brain health, biomarkers of recovery, and trial design. We are so glad to have you with us today, Dr. Pooja. And without further ado, you can start.
Thank you so much. Thank you for having me. It's always an honor to speak with all of you. I hope someday to meet you in person, but it hasn't worked out yet, but I always enjoy speaking with all of you. So let me share my screen here. Just give me a second, hopefully. Oops. One more moment, please. Sorry, I'm having one thing I have to fix. Let me try that again. Okay, put this on full screen. So you should be able to see me.
Yes, doctor. Yes, doctor, I can see.
Wonderful. Okay. Well, and I believe I'm slotted for about 30 minutes. So a little less than 30 minutes. So my focus, I see a hand being raised. Is there any questions or with technical difficulties?
No, we can hear you so well. You can start and we'll keep the question till the end.
Okay, great. Okay, thank you. Thank you. Okay. So my job is to talk to you about updates from the International Stroke Conference in less than 30 minutes, which is almost impossible, of course. So what I'm going to do is go ahead and, well, first of all, here are my financial disclosures. Just so you know, I do grants from government, but I also get a grant from Cerenovus, which is a subsidiary of Johnson & Johnson. I do some consulting all towards therapeutic development. And I just got a study drug and trial support donated for an NIH study called Sister for a novel clot dissolving agent. So just so you know, my financial disclosures. Knowing that I can't do it all, I decided to focus on what has stayed most important for me in the International Stroke Conference, which was actually, there were 3 sets of data that seemed particularly practice changing. So that's going to be my focus with you all today, that I'm frankly quite excited about. They were all in the late breaking session. And so I'll start one by one. We'll start with large core trials. then blood pressure management after large vessel occlusion, and then some interesting data about mild stroke that may or may not change your practice depending on what you were doing before. So let's talk about large core. As you know, for acute ischemic stroke patients, we've had this concept of the core and the penumbra. In this picture here, the core is red, and if green is the penumbra, the area with reduced perfusion but hasn't completely died, and of course the yellow is just not going to die, just a little bit less blood flow, the oligemic area. And when we open up an artery, a large vessel occlusion, our goal is to keep that predicted core no bigger than it was predicted to be. But if we don't recanalize the patient, we always talk about how we want to try to prevent that core from expanding and to include that penumbral area. And with that in mind, that's been our paradigm for expanding the time window. 0 to 6 hours, we've been treating patients with using aspects, and then 6 to 24 hours, we actually look for the core and penumbra mismatch, or specifically the core size with clinical or penumbra mismatch, to say, yes, this is somebody I should actually take even in the extended time window. You all know well the aspect scoring that we use to in the 0 to 6 hour time window, and also in the extended time window to look for any areas of permanent injury on the CT scan. Well, and you all know that within 6 hours, the pivotal trials that establish that thrombectomy is highly effective in treating our patients with acute ischemic stroke all used some sort of selection, for the most part, except for Mr. Clean, which still seemed to use some sort of selection, but all used some sort of selection, whether it was aspects or perfusion or penumbra volume, to choose patients for treatment. And generally what we say is that they should have a relatively good CT scan within less than 6 hours to take them for thrombectomy. And this is what our guidelines say as well, and what we all practice. Some sites still do perfusion imaging, but I would argue that we don't actually know what it means in the very early time period, and we shouldn't be making decisions based on it. Well, then the extended time window trials came along, DAWN and DIFFUSE-3, and they told us that if we select patients that have a smallish core, but have either significant clinical symptoms or a larger penumbra, then we should treat them in an extended time window. So that's what we do. And so if we have a relatively good scan on CTP core based on a CBF less than 30%, and we usually say less than 70 cc's, we go ahead and take those patients if they have significant symptoms. And I can talk more about this if you find it helpful, but I'll go on to the newer data. About a year ago at the International Stroke Conference, we saw the Japan Rescue Limit trial, which actually randomized patients with aspects 3 to 5 on MRI. Aspects 3 to 5 on MRI are probably like aspects 4 to 6 on CT. And so we were already treating 6s. So this made, frankly, this trial a little more confusing for me as I was thinking about whether it changes my practice. They took patients within 6 hours. They gave a lower dose of thrombolytic than we give in the US and that you give in the Middle East and North Africa. They gave a much smaller fraction of thrombolysis than we typically give. Not much smaller, but a little bit smaller, I should say. But they showed a significant treatment effect. They showed when you looked at patients who were at least ambulatory, and at most able to take care of themselves completely with no symptoms, that treatment effect was 31% versus 13%. For every almost 5 people we're treating, we're bringing 1 patient back to walking or better. And they did show a little bit of symptomatic hemorrhage associated with that, probably, but again, that benefit despite that symptomatic hemorrhage. So this trial left us thinking, okay, well, we probably can start to think about treating these larger core patients. We all wondered that anyways, because those early trials were so effective, some of the most effective treatments in medicine. So we thought we probably can bend these rules quite a bit, but this gave us more confidence. And now, thanks to the data that we saw in February, that's also been published in the New England Journal of Medicine from both Angel Aspects and SELECT2, we've learned that it's actually pretty clear cut that these large core patients benefit from thrombectomy. So very exciting data. I show you here a chart of what kinds of patients they enrolled. These were both phase 3 randomized trials, and I'll tell you a little bit more about them. Angel aspects and SELECT2 had upper age limits of 80 and 85. Patients were not allowed to have any pre-stroke disability, and they had to have ICA or M1 intracranial occlusions, that had to have an NIH stroke skill score of 6 or more, and they enrolled patients up to 24 hours. So they lumped together the 0 to 6 and the 6 to 24, which in my mind are those two treatment paradigms we've had. In Angel aspects, and I find this a little bit confusing, but I understand why they did the criteria the way they did. They allowed patients who had the worst scans, aspects less than 3, if their perfusion volume looked like it was not among the worst, but just a little bit higher than we normally treat. They allowed aspects 3 to 5 without any exceptions because we already were starting to think we could treat those patients. And if they did also allow patients who were aspects greater than 5 that were 6 to 24 hours, but had a perfusion volume that was 70 to 100 cc's. Again, getting that group of people that we're typically not treating right now in the 6 to 24 hour time window, just a little bit more to include that group. SELECT2 made it a little bit simpler for us. They said aspects 3 to 5 or penumbral volume of 50 cc's or more. Either of those were included in the trial. And you might ask, why did they use the threshold of 50 cc's? That's something I've thought about when the trials previously used 70 cc's. Well, actually, in both DAWN and DIFFUSE-3, it turned out that the perfusion volumes, or actually, I'm sorry, I just realized that's a typo. That should say core volume, not perfusion volume. The core volumes were, for all of these cases, it's core volume, CBF less than 30%. But the core volumes in DIFFUSE-3, to give you a sense, the upper limit of the interquartile range was 22 cc's. So these were actually much smaller than they intended when they were allowing up to 70 cc's. For whatever reason, they didn't get that. So they wanted to make sure we're really seeing benefit when we go above, even in that 50 to 70 cc range. So to tell you a little more about SELECT2, it was led by Amru Siraj here in the United States at the Cleveland Clinic, and it was an international trial sponsored by industry, and it specifically, again, focused on these patients that I've talked about. It randomized patients with thrombectomy plus medical care versus aggressive medical care alone for up to 24 hours. A few things to note: the patients look like the kind of patients we were interested in knowing the answer about. These were patients with a median age of in the 60s. They had NIH stroke skill scores of 19, so these were big strokes. About half of them had M1 occlusions. Some of them had tandem occlusions, about a third. About 20% were treated with thrombolysis, but again, this is the 0 to 24 hour time window. So this was all kind of what we expected. And I would just add that they actually saw median core volumes of the range that we would be interested in studying, 81 cc's with an interquartile range of about 59 to 119. Similarly, whether they used CT or MRI. So again, the very appropriate population, and they saw a pretty substantial treatment effect. They saw, you can see here that the numbers go very much in the right direction, and it's always helpful to think about it in terms of functional independence, modified Rankin 0 to 2 at 90 days, and you can see the treatment effect here was 20% for endovascular therapy versus 7% for medical care. So that treatment effect comes to about 13%. Every 8 patients or so we're treating, we're making 1 patient functionally independent. So very exciting. They also saw more early neurological improvement in these patients. They saw other secondary measures all line up appropriately. About 80% successful reperfusion rates, which is exactly what you'd expect based on how our treatments are working right now. They interestingly didn't see increased hemorrhage, and that to me was symptomatic hemorrhage. That was very exciting. They did show some early neurological worsening. significantly more in the thrombectomy arm, and they speculated that this could be because of edema in that reperfusion setting. But bottom line is, overall, they still turned out to be better off that as a group, these patients that got endovascular therapy, raising this question, who are these patients who had the early neurological worsening? Only one of them was a symptomatic hemorrhage, and they all tended to not do well. And if we could figure out who those were, we would like to take them out of our future treatment plans with thrombectomy. So that will be an area of interest. Death rates were maybe slightly improved, certainly comparable with thrombectomy. There were, access site complications and vascular injury, which will occur sometimes, and you can see the rates there. When they did subgroup analyses, all of us were wondering, those really big strokes that are 150 cc's or more in core, did they really show evidence of benefit? And they did. You can see that in the bottom of this chart here. And you wonder, when they were really late, did they show treatment of benefit? And it looks like they did. NIH stroke skill score greater than 20 or less than 20, similar, really everything favoring treatment, which is so exciting for our field and so much easier for us to think about. When you look at aspects, similarly, the 0 to 2 and 3 to 5 both suggested that endovascular therapy was better. They had far fewer 0 to 2s, so it was less confident. And I should say they didn't intend to enroll 0 to 2s. It was only 20 patients. So I don't think this trial tells us we can treat patients with aspects 0 to 2 necessarily. It didn't matter whether they had mismatch or not. I think that's a really important fact to know. You might say to yourself, then what's going on here? If these patients don't even have mismatch, what are we doing when we're reperfusing such big strokes? And the only answer that I can come up with, and most people have come up with, is that clearly there are probably islands of normal tissue within that infarct, and we might be actually preventing full density of infarction in that large infarct volume. We might also be preventing some patients from more edema. I think the edema question is quite confusing right now. But bottom line is that it seems like our paradigm that we must see penumbra is sort of falling on its head, at least for thrombectomy. I don't think, in fact, we've seen the opposite. We have thrombolysis data that if you just take all comers more than 4.5 hours, they're not going to show benefit. But clearly in thrombectomy, we seem to be able to expanding who we take, and based on our current treatment paradigms overall and our current devices, where we're doing them for a big help. Let's talk about that second trial. So the second trial was Angel Aspect, and it was in China, and had, remarkably similar results. Like I told you, I found the inclusion criteria a little more confusing to remember, but the logic was certainly sound for how it was designed. These patients were also in their 60s. Similarly, they had a predominance of M1 occlusions, 63%. Their median NIH stroke skill scores were 15 and 16, and their aspect scores had a median of 3. You can see their infarct core volumes ranged from 30 to 90 cc's. It's a little confusing that they had the 30 cc's because obviously we would normally take those patients, but again, they were allowing either aspects or that combination of aspects or CT perfusion. So you can imagine how patients got in that way. About 30% had thrombolysis. And you can see the time distributions here. The majority of patients were 6 to 12 hours from stroke onset. Again, beautiful results you can see with better outcomes in those many more patients with modified Rankin 0, 1, or 2 if they got endovascular therapy compared to medical management. So in this case, if you think about it in terms of the 0 to 2 modified Rankin, the treatment effect was about 19%. So about for every 5 patients we treat, we make 1 patient better in terms of functional independence. Similar death rates, actually increased symptomatic hemorrhage rates, not so high that we'd be worried, but enough that we have to recognize this risk. And they did not comment or show that neurological worsening. So that's where we are in the field. We now have, and I took this slide right out of, it's a beautiful slide from the Angel Aspects group, but it shows basically, we've had Rescue Japan Limit telling us certainly we can increase the limits of who we treat with large core, and then Select 2 and Angel Aspects showing us we can really increase them quite a bit, and also in other countries and populations. Now, I am really excited, and I know you must be too, to see data from 3 more trials. They've all ended and will be presented in Munich at the European Stroke Organization conference in May. Tension, which is in Europe, and is looking at aspects 3 to 5. Importantly, it has no upper age limit. I think that's really important for us to think about how far we push the envelope. In extremis lasta, which is largely in France, but other parts of Europe and a little bit in the US. And they're including patients with aspects 0 to 5. And if their aspects were 4 to 5, they had to be greater than 80 years old. They had, and then I guess the other thing to note is they also had no upper age limit. They're at the 6.5 hour time window, whereas tension was at the 12-hour time window. And then finally, Tesla, which is basically testing in the United States aspects 2 to 5. They do have an 85-year-old age limit, and they do go out to 24 hours. So they really will be the full population, and we'll see if we see very similar results to Select 2 and Angel Aspect. So I can tell you that, in the United States, we are working through the American Heart Association. I feel privileged to be a co-author. We're writing a scientific statement about large core patients. We're starting to write that statement based on the first 3 trials, and we're going to finish it up promptly after we hear the results of the last 3 trials, and hopefully send this for publication in the summer so that we can help synthesize and help everybody what should be probably our newer standard of care. I can tell you right now, I am starting to take patients with large core. I sometimes get resistance from some of our community interventionalists, but not from my own team. So, it's about education, but I think these data are quite convincing. It's really hard to not take a patient you could improve, but obviously talking with the patient, thinking about the whole medical context and how sick they are and in general and what they're looking for. So I'm going to switch gears and much more briefly, so I can stay on time, talk to you about blood pressure after endovascular treatment. To just say that, so that was a randomized pilot trial led by, I'm very proud to say, my mentee, Eva Mystery from University of Cincinnati, who did this through a Career Development Award, and had several wonderful collaborators. And the idea was to tackle this question that if a patient has successful mechanical thrombectomy, where should their blood pressure be? The guidelines right now say less than 180/105 in the United States and also in Europe. But there's then this question of whether we should be more aggressive. You've opened the vessel, so they don't need that high blood pressure. And maybe it's actually causing harm, edema, hemorrhage. When she surveyed patients or sites across the country, 60 StrokeNet sites, almost 60 StrokeNet sites, she saw that we're doing all different things. I can tell you several in my group have generally been keeping blood pressure less than 160 if they have a TICI 2B or 3 recanalization. Some people are saying let them go to 180. Many we're pushing them below 140. A few are even pushing them below 120. And so there have been 2 randomized trials right now that have failed to show the benefit of lowering blood pressure after endovascular therapy. But the thought was maybe they were pushing too low. Blood pressure target pushed patients below 130, whereas Enchanted pushed patients below 120 again. And and they had worse outcomes, and there was no obvious reduction in symptomatic hemorrhage. So for these reasons, the questions remain, well, what about moderate reduction? So Eva's prospective data that we pulled together across the United States showed that if you just look prospectively, the difference between good and bad outcome after Chicky 2B3 reperfusion was probably at a cutoff about 160. So similar results have been seen in other cohorts. So she designed a randomized trial of 120 patients. It was a futility clinical trial. In other words, the goal was just to say it's not futile to keep studying this. I'm not seeing clear evidence of harm. And so we randomized patients to either a target goal of just less than 180, less than 160, or less than 140. Adults with successful reperfusion, TICI-2B3, anterior circulation, and some key exclusion criteria such as no heart failure in terms of an ejection fraction less than 30%. It had multiple primary endpoints. We were looking for harm, whether it was based on infarct volume or based on modified Rankin score, the utility weighted modified Rankin score. And of course, we were studying hemorrhage. And the idea was that it was a futility design with where we would consider the study futile if there was unequivocal evidence of significant harm or there was a predictive probability of success in a future trial less than 25%. Either of those would mean this is futile. And I won't get into the statistical hypotheses in too much detail, except to say that it was basically a model-driven approach in terms of how those decreasing blood pressure targets could theoretically increase final infarct volume if it was causing harm, or could progressively decrease modified Rankin scores if it was causing harm. And both of those were based on external data and vetted with a really excellent group of statisticians. And the punchline here was that as far as final infarct volume went, there was this is where we landed. This is sort of benefit on this side. This is harm in this side. Maybe a slight benefit, but really questionable. And that was true even if we adjusted for key variables. And then actually we started to hit the direction of harm when it came to clinical outcome, which is concerning. And then I'll say that we didn't see progressively reduced symptomatic hemorrhage. If anything, maybe there was a slight increase in hemorrhage. It might just be noise, though. The numbers are so small. When we looked at the predicted probability of a future trial being successful based on the data we saw, with 1,500 patients, we were right at our threshold of 25%. And then we looked at bigger numbers, and even with a 2,400 patient population, we would be at a 28% efficacy percentage probability of success. So not very impressive in terms of investing big resources. So we did go get good fidelity to intervention in terms of comparing patients less than 80 versus 180 versus less than 160. The 140s and 160s overlapped a little bit. We failed to demonstrate futility, but we couldn't, and which means we couldn't still rule out the potential for harm. And the point estimate for treatment effect was actually in the direction of harm. And we were right at the mark for our pre-specified threshold in terms of predicted probability of success. So at this point, we've concluded that continuing to a phase 3 trial is not the best use of our resources. There are important questions that are much more likely to be helpful, especially when you also consider the other two trials, Enchanted 2 and BP Target. There are 2 more trials that are going to give us additional insight, and I happen to know that one of them has stopped early for safety. So I think this story will be complete very soon, with papers actually under review right now in a major journal. So our punchline with this data is that there's a signal of harm with only a possible marginal benefit. And so our take-home message to you is that we should that we don't think you should be pushing blood pressure below 160 or below 140, even if your patient has TICI-2B3 results. Of course, there may be individual circumstances that make you think of that differently. There's always that. So in the last few minutes, I'm just going to tell you about a trial that maybe doesn't really totally change our practice, but gives us confidence in what I think we already knew. I might be a little biased because it builds off the PRISMS trial, which I ran in the United States. It's called the Aramis study. It has a trial. It was done in China with several excellent collaborators. Their paper is currently under review. Just to remind you, the randomized PRISMS trial looked at TPA, IV TPA versus placebo in patients with not clearly disabling deficits, which we defined based on their activities to do basic ADLs or return to work. And we saw we had to stop early due to operational futility, but we had about a third of the patients enrolled, 313, and to our surprise, we actually saw, if anything, good outcomes favoring the control arm by a few percentage points. Certainly not anything to help me energize for a follow-up trial. And we saw the expected symptomatic hemorrhage rate of about 3.3% with alteplase compared to controls. And so guidelines in the US and Europe did change from 2B. In other words, we were conflicted about treating patients with TPA who have mild non-disabling strokes to probably no benefit, although the evidence is limited and most of us wouldn't treat these patients. In the meantime, the double antiplatelet therapy data was coming out, and the POINT trial became positive during the time of the PRISMS trial. So, sorry, here's the, whoops, I meant to give you the slide of the POINT trial and I gave you the MATCH trial. But you can trust me to know that the POINT trial and the CHANCE trial looked very similar in that they showed in patients with low NIH stroke skill score or even TIAs that we could reduce stroke recurrence rates by giving dual antiplatelet therapy early, less than 24 hours in China with the CHANCE trial, and less than 12 hours in the POINT trial in the United States. These were using aspirin and clopidogrel. And so Aramis decided to do a very interesting study where their premise was that IV TPA was sort of the standard of care, which I might argue is not true, but that's okay. It's still really interesting data. And then basically wanted to see if it was non-inferior to randomized patients instead to give them aspirin and clopidogrel. The idea was that they got the clopidogrel and aspirin early versus the alteplase, and they took the medication for 14 days. And patients had to have an NIH stroke skill score of less than or equal to 5, and you can see the other inclusion criteria there. And their non-inferiority margin was 4.5%. So they were going to declare non-inferiority if dual antiplatelet therapy was not within 4.5%. In other words, it would be inferior if it was greater than 4.5% worse. And to make a long story short, they showed that, in fact, the patients on DAP looked like they did slightly better. So it was not non-inferior. And interestingly, these patients looked like exactly the patients you'd want to study. Their ages were in their 60s. Their median NIH stroke skill scores were 2. They were treated at about 3 hours from onset. And you can see there that, interestingly, that number again is in favor away from alteplase by about 2%, which I found fascinating. These patients generally did extremely well, better than the PRISMS population. And so, long story short, we came away with saying that, and they showed that bleeding was actually a little bit increased, not as much as in PRISMS, but a little bit increased with IV thrombolysis. With subgroups, they saw really no evidence that would make you think differently about particular subgroups, except maybe the greater than 3 NIH stroke skill score favoring alteplase, which might not be surprising if some of those might have been on the border of disabling. All the rest favored dual antiplatelet therapy. They did have a lot of crossovers, so we have to keep that in mind. But I think what we learned was that actually this study actually, to my satisfaction, and I'll be interested in other people's thoughts, but to my satisfaction, actually confirmed the PRISMS trial and sort of confirmed what we do, which is dual antiplatelet therapy for minor non-disabling strokes. So I'll end there. I think I went just a couple minutes over, hopefully still enough time for my second speaker. And I want to really thank the trial teams who shared all their slides with me. And thank you very much. I always enjoy an opportunity to speak with all of you. And I'll pass this on back to the moderator. Thank you.
Okay, thank you so much, Dr. Booja. That's a fantastic talk. We will keep the question and answers till the end. So don't forget, please, to post your questions in the box below. And Dr. Athari, you can go ahead with our next speaker.
Thank you, Dr. Nuran. It gives me extra pleasure today to introduce my mentor, my colleague and my friend, Dr. Talia Field, who's going to give us a talk regarding cerebrovascular thrombosis in 2023. Dr. Field is a stroke neurologist and a clinician researcher at the University of British Columbia, where she is an associate professor and holds a Soder Family Heart and Stroke Professorship of Stroke Research, with a focus on clinical trials and stroke in younger adults. She's interested in stroke, vascular cognitive impairment, and other post-stroke sequelae, particularly in high-functioning survivors, and engages in collaborative work with patients to best learn how to characterize these outcomes in research. She is the principal investigator of the SECRET trial and parallel registry, which is examining treatment strategies and prognosis of cerebrovascular thrombosis, and is the co-chair for the Canadian Stroke Best Practice Guidelines Committee for the Management of cerebral venous thrombosis. The mic is yours, Talia.
Thank you so much, Dr. Salmeen, for the kind introduction. And thank you so much to MENASO for the opportunity to speak to you all today. I'm very pleased to have this opportunity. I'm coming to you from Vancouver, where we had the pleasure of having Dr. Salmeen both as a resident and a fellow. And if you're thinking of doing a fellowship, it's a great spot. This is just a view from the hospital, both when the weather's what it's usually like in Vancouver and when the weather's nice. So these are my disclosures. Mainly, I'm receiving in-kind study medication from Bayer Canada for the SECRET trial, and also some honoraria for consulting in addition to research funding from nonprofit organizations and governmental organizations. Hear me now. Just a brief overview in 20 minutes with some focused updates about cerebral venous thrombosis. I won't repeat myself just in the interest of time, but we'll get going. So first of all, just with regards to some updates in epidemiology, I think in general, we think of cerebral venous thrombosis as a disease that primarily affects younger women. And while this is true, I think there are some things to keep in mind just about what we've learned with epidemiology in the last couple of years. One thing is just to kind of get a updated sense as to what the incidence of cerebral venous thrombosis is. Older estimates were as low as 1 per million per year. I think, with the accumulation of evidence over time, there have been reports that the incidence is more common than what was previously reported. But I think that this is due in large part to increased use of vascular neuroimaging over time. And in particular, those increases have been in men as compared to women. And I think also this is just because there may be a lower index of suspicion in men, particularly older men. And now with vascular neuroimaging, I think we're more easily able to make that diagnosis. Another possible explanation that may be contributing is that frailer patients who may have previously died, like those with malignancy who may be having a hypercoagulable state, now have longer life expectancy and may be more likely to develop cerebral venous thrombosis as a complication. So this is US data just in the upper right-hand corner by Dr. Chataverdi, and basically just showing that there have been increases in reports of incidence of cerebral venous thrombosis over time, mainly in men. This is data from my province of British Columbia, which has 5 million people, and you can see that, again, when you break it down by sex, the increases in incidence over time have been most pronounced in men, these gray boxes here, as compared to in women. So just to make the point again that I think that this can be in part due to increased use of vascular neuroimaging, I've just kind of superimposed two graphs here. One is the increase in reported incidence of cerebral venous thrombosis in British Columbia over time. This is 2000 to 2005, 2006 to 2011, and then here 2012 to 2017. And over the same period of time, I've just shown you the number of CT angiograms we were doing at my center just for all purposes in the emergency room. And as you can see, there were sharp increases over time. So just something to keep in mind. However, we do know that prevalence still remains higher in younger women. And in particular, the risk of onset for cerebral venous thrombosis is earlier in those with sex-specific risk factors, mainly use of the oral contraceptive and being pregnant, and in particular in the postpartum period. We know with men, the risk factors are different. There are higher proportions of cerebral venous thrombosis that are associated with trauma and infection. infection. And another thing to keep in mind that I think is underemphasized is that the sex differences tend to even out as patients get older. And this is mainly due to the increased prevalence of cerebral venous thrombosis in the context of malignancy. So the other thing I would say, especially to a Middle Eastern and North African audience in particular, is that we're really in better need of population level epidemiological data with regards to the incidence of cerebral venous thrombosis. For example, there are some countries like India where very high incidences are reported, but it would be really helpful to get some more detailed information and to determine if risk factors are different and how much may be due to genetic or other population level differences as opposed to things like differences in postpartum care or use of antithrombotics or things like that. So it would be very helpful. The most updated epidemiological data tends to be from Europe and North America. So I would put that challenge to this audience to give us future population-based data. We know that the commonest risk factors for cerebral venous thrombosis tend to be related to exogenous hormones, accounting for about 50% of all cases in series. Also, major risk factors include acquired or genetic thrombophilias and malignancy. One thing to keep in mind with the oral contraceptives is that there may be a synergistic association with body mass index. So there's been one study by the group in the Netherlands that looked at patients who were on oral contraceptives and with categorizing BMIs into kind of normal weight and lower class obesity versus higher class obesity. And there does seem to be a synergistic relationship where your risk of cerebral venous thrombosis goes up with the oral contraceptive, particularly in patients with higher rates of obesity. And then the other thing is that patients that have earlier age of onset of cerebral venous thrombosis often have had their event in the context of multiple risk factors. So there may not just be the synergistic effects between the oral contraceptive and obesity, for example. There are also lots of other multiple factors that may be at play for certain patients. We do know, again, that cerebral venous thrombosis is associated with sex-specific risk factors, and in particular related to the pregnancy and post-pregnancy period. There have been some reports that suggest that, it's less risk associated with pregnancy as much as the early postpartum period, in particular the first 6 weeks, though the risk in some series may be increased slightly towards the end of the third trimester. Risk factors associated with pregnancy in the postpartum period include having a cesarean section, preeclampsia, increased age, infection, and excessive vomiting. CVT associated with pregnancy in the postpartum period has also been reported to be associated with a higher risk of seizures. When counseling women that have had a previous cerebral venous thrombosis in the context of pregnancy or the postpartum period, certainly this is not a contraindication to future pregnancies. However, people should be aware that their risk of having another venous thromboembolic event, both cerebral venous thrombosis or peripheral venous thromboembolism like DVT or pulmonary embolism, is higher. And those patients should be treated prophylactically with low molecular weight heparin during their pregnancies. The other thing I would just say is that when you think about stroke associated with pregnancy, unlike stroke otherwise, where cerebral venous thrombosis is comparatively a rarer cause of stroke, with association with pregnancy in the postpartum period, it is almost as common as that of an intracerebral hemorrhage or ischemic stroke. And just one last thing about epidemiology is just, considering what the COVID era did to our understanding of cerebral venous thrombosis epidemiology. I'm not going to talk about vaccine-induced thrombosis with thrombocytopenia, which, was a rare complication related to an autoimmune reaction to the adenovirus vector vaccines, in particular the AstraZeneca and Johnson & Johnson vaccines. That was a particular type of reaction associated with cerebral venous thrombosis. So outside the scope of that, just the relationship between COVID infection and cerebral venous thrombosis. I think our understanding of the epidemiology and how subsequent waves and variants of COVID affected epidemiology is still evolving. But what we do know is just comparing, estimated incidence in the pre-COVID versus the COVID period. 10 to 20 per million in the kind of non-COVID literature versus rates as high as 40 per million in communities within the first 2 weeks of infection, and even higher in hospitalized patients. One good paper had an estimate of over 200 per million. Others, the risk has been cited as high as 800 per million. The other thing is just, CVT usually counts for less than 1% of hospitalized patients with stroke in non-COVID series. And in the available literature, it's been about 5% of stroke. Again, kind of how the alpha variant of COVID versus later variants may have affected this epidemiology isn't entirely known. But there was a recent international series that my colleague Tan Nguyen put together from nearly 200 centers internationally. And what we did see is that, there was not a spike in admissions related to CVT in 2020. However, early in 2021, associated with the Delta variant, there was a spike in admissions, and then a second one due to these rare complications related to the vaccine. So one thing I like to emphasize that is not new, but should always be remembered is that with cerebral venous thrombosis, even though about 40% of patients will have some degree of intracranial bleeding, the standard of care treatment and what almost everybody should be getting is therapeutic anticoagulation, and immediately. Unlike arterial sources of hemorrhage, the pathophysiology is different. If you're able to facilitate recanalization and prevent clot extension, you are helping to reduce the venous pressure and therefore reduce the impetus for the bleeding. A small proportion of patients, less than 10%, may have later bleeding in the context of anticoagulation, but this is usually early on complications related to the disease itself as opposed to complications related to the anticoagulation. With regards to kind of moving into that secondary prevention period, how long do we actually anticoagulate for is a question. Most people in practice, if people don't have a permanent or very high-risk thrombophilia to justify ongoing anticoagulation, most people will anticoagulate for between 6 to 12 months. And, I think one question is, should we target recanalization as our goal in deciding how long we anticoagulate for with cerebral venous thrombosis? And, the literature has really not been that clear in helping us understand what the relationship may be between recanalization and prognosis. Previously, because cerebral venous thrombosis is quite rare, there have been smaller series of variable quality. Some have been retrospective, some prospective, looking at the relationship between recanalization and prognosis, and the timing of imaging has been different from study to study. We've recently done an updated meta-analysis that does suggest that on the whole, there is some association between recanalization and improved prognosis. Patients who recanalize have an odds of improved outcome that's about 4 times as that of those who have not recanalized at all. However, how much of that is due to gains later on with recanalization past the acute period versus recanalization early on is not known. However, one of my colleagues in Portugal has done what I think is one of the most interesting studies to be done in cerebral venous thrombosis within the last few years, looking at the association of very early recanalization and prognosis. So this is my colleague, Diana D'Souza. And basically what they did is they repeated imaging in people with cerebral venous thrombosis within a week after starting anticoagulation. So this is something that is not usually done in studies of cerebral venous thrombosis, looking at this very early recanalization. And what they found, which was very, very interesting, is that, even within 1 week of starting anticoagulation, the majority of patients patients had at least partial recanalization that early on. So number one, people recanalize early in the context of anticoagulation. And then the other thing to keep in mind is that having earlier recanalization was associated with less evidence of brain injury. So patients who had non-hemorrhagic lesions had less expansion of those lesions, and people were also less likely to develop new non-hemorrhagic lesions. So again, kind of evidence of that early brain injury was reduced in patients that had earlier recanalization. So I think that's very interesting information that has not previously been reported. So, that being said, one might think that, earlier recanalization would be associated with better functional outcomes. I think the challenge is, how we define functional outcomes with cerebral venous thrombosis. So number one, this prospective imaging study I was just talking about was not powered to look at differences in functional outcomes. But the other thing to keep in mind is that, the majority of patients with cerebral venous thrombosis will be functionally independent even at baseline. This is a disease that has, a better prognosis than ischemic or hemorrhagic stroke in general. However, patients tend to have complications like headache and fatigue and mood and cognitive problems that are not necessarily very well measured by the modified Rankin scale because, patients may be functionally independent. And with these subtle symptoms, that's not really captured beyond what's still considered to be an excellent outcome. So, I think we still have a ways to go in determining the association between early recanalization and prognosis and whether there are any gains later on. So I think that moves into the next question as to whether or not there is a role for routine endovascular treatment, because of course, that may be a way to get recanalization very early on. But I would say that there is still a lot that we don't know about routine use of endovascular therapy for cerebral venous thrombosis. And this is why most centers are using it as a rescue tactic for patients that continue to deteriorate despite best medical management in most cases. So number one, I would say that unlike endovascular therapy for acute ischemic stroke, the prognosis is different. Again, most patients will end up with functional independence and may even begin being functionally independent. So, the risk-benefit calculus is different in pursuing endovascular therapy. The second thing is that endovascular therapy may be more risky for cerebral venous thrombosis in general than it is for acute ischemic stroke. Catheters are not designed for the large venous sinuses. This is just an illustration just showing you kind of what the large catheters would look like in venous sinus and kind of what the size of an ideal catheter would be. The venous endothelium is delicate and there's risk of puncturing cerebral veins and causing additional complications. So, when the ideal techniques are still not known. So we don't have the right tools and techniques are variable. And because it's a rare disease, there's less experience from operators. So there are a number kind of unknowns there. And then the other thing is who the best candidates may be, whether it is patients that have these, worse presentations at baseline or whether patients that are more mildly affected may be candidates as well. So at this point, I would say the jury is still out. There was one clinical trial that was randomized, the TOAC trial, that randomized patients that had markers of worse prognosis and randomized to endovascular therapy versus best medical therapy. And endovascular therapy was just whatever they were doing at that center. So there was a wide variety in terms of techniques. And how they defined worse prognosis was also fairly general. Patients may have had depressed level of consciousness or encephalopathy, any involvement of the deep venous system, and any amount of blood on their scans. So patients were randomized 1-to-1 to one versus the other. And the trial was stopped early due to low recruitment because, not surprisingly, it's a rare disease and patients that are severely affected are even rarer. So, the trial recruited small numbers overall, and there was no difference in the primary outcome of an MRS of 0-to-1 at 12 months. And if you're tempted to read any differences into these grotto bars here, what I would tell you is that these numbers are very, very small, and this is not a significant difference in a very small trial. The other thing to keep in mind is that the endovascular therapy group had more complications. Basically 1 in 10 had a sinus perforation with endovascular treatment. So, again, this is a procedure that's not without risk. And again, the techniques were variable. 1 in 4 had thrombolytics, but there were a number of different techniques being used. So again, I think we need more information before declaring that endovascular therapy is the right treatment for all patients with cerebral venous thrombosis. But we are still using this in select cases. I would say, again, there may be some patients that benefit, but it's hard to know at this point. These are just some cases from my own center. This was a woman who had presented, and you can see she has deep venous involvement. She had very rapid deterioration despite a fast presentation and being put on low molecular weight heparin right away. That was therapeutic. So we brought her to endovascular therapy because she was worsening despite best medical therapy. My colleague Raju Heron was the endovascular was the interventionalist, and this is just our before versus after, and you can see he got wonderful recanalization, fortunately, and she actually went on to make an excellent outcome, and I saw her about a month later in clinic, and she was doing very well. This is a patient that has a similar looking scan and progression, but was treated conservatively. So this woman is younger, 47, who had a rapid change in her level of consciousness. They did put in a drain related to her hydrocephalus, but opted not to treat her with endovascular therapy. And her scan normalized fairly quickly, but she was still having significant functional issues, even at 3 months following, with cognition problems, language and mobility issues, and a lot of functional dependence. So, again, we don't know who the best candidates are. Can I say that this woman would have had any difference in prognosis than this previous patient? No. I mean, certainly at this point, we can't say that, but, it is interesting and will lead to hypothesis generation. And I think in the future, once we've gathered some more information, that may be the time to reconsider doing another trial. So just moving on quickly to use of direct oral anticoagulants for cerebral venous thrombosis instead of warfarin. Previously vitamin K antagonists like warfarin have been standard of care for this longer term period of anticoagulation after the acute phase. And there is a body of evidence that is accumulating to suggest that, at least in lower risk patients, that this is a suitable option. So there have been 2 randomized trials to date that have been published. There's the RESPECT CVT trial, which looked at dabigatran versus warfarin. And then there's the Einstein Jr. trial, which is a pediatric trial of venous thromboembolism, but there was a large subset of children, more than 100 children with cerebral venous thrombosis. And those patients were randomized 2-to-1 to the equivalent of 20 milligrams of rivaroxaban versus standard of care, so either warfarin or low molecular weight heparin. So, and there was also a large retrospective study just looking at patients that were treated either with warfarin versus DOAC in routine care for cerebral venous thrombosis. So, retrospective study, routine clinical care data, so a little bit different than a randomized trial, but, it was a large study. So, what have we learned? Again, in lower risk patients, this may be a safe option in patients that are otherwise suitable for direct oral anticoagulation. So, patients who are not pregnant or breastfeeding, which is a contraindication to use of DOACs, patients who do not have antiphospholipid antibody syndrome, which also has a higher risk of recurrent arterial and venous events when treated with DOAC. So other patients who are awake and able to swallow. These studies did not have a large proportion of patients with malignancy, is another thing to keep in mind. But basically, there were no major safety signals that suggested that DOACs were not an appropriate strategy. So in RESPECT CVT, there was 1 major bleed, a GI hemorrhage with dabigatran, and 2 intracerebral hemorrhages in the warfarin group with 6 months of treatment. Similar rates of recanalization between groups. In Einstein Jr., the pediatric rivaroxaban trial, there was 1
recurrent venous thromboembolism in the control group, no major bleeding with rivaroxaban, 5 clinically relevant non-major bleeds, and 1 subdural hematoma in the control group. And this was with 3 months of therapy. And with ACTION CVT, again, keeping in mind that these were patients who were not randomized, so there may be some confounding by indication. There were no differences between groups with regards to recurrent venous thromboembolism, but there was a reduction in major hemorrhage comparing the warfarin group to the DOAC group, where DOACs were associated with a lower rate of hemorrhage, and this was primarily due to a lower rate of intracranial hemorrhage. So again, the bottom line is that right now there are no obvious major safety signals to suggest that DOAC is not an acceptable choice in patients who are stable, who are appropriate for oral anticoagulation. The other thing that I would just mention is that these studies used at least 5 days of lead-in parenteral therapy, so either low molecular weight heparin or unfractionated heparin, before transitioning patients to DOAC anticoagulation. Trial that we've been running nationally, the SECRET trial, will be presenting the results at the upcoming European Stroke Organization conference in May. And there's also a registry called DOAC CVT run by the group in the Netherlands that's also gathering more data as well. So just the last word with regards to prognosis and what we're learning. So ACTION CVT, because it's been such a large cohort, has been great for deriving some more additional information about the prognosis of cerebral venous thrombosis. There's a new risk score that they've derived, for example, for risk of morbidity and mortality. But in general, what most series of cerebral venous thrombosis have shown us is that, again, overall, most patients will be functionally independent. There are fairly low rates of death kind of early on in the hospitalization phase. Recurrence tends to be kind of gradual over time. It's not, super front loaded like the risk of after minor stroke or TIA that we think of with ischemic disease. In general, risk factors for poor outcome tend to be in patients who are older and have malignancy are the most kind of common things between series. Deep vein involvement, intracranial hemorrhage are factors associated with early presentation that may be associated with worse prognosis. And it's a little inconsistent between study to study as to whether or not male sex may be an independent risk factor for worse prognosis or whether it's simply associated with older age. The very last thing I'm going to say is that, again, I think we need to listen to patients in terms of understanding what the next important series of outcomes needs to be in terms of assessing the prognosis of cerebral venous thrombosis. We had a patient forum and we had what's called a graphic recorder joining us. So kind of doing drawings in keeping with the conversation. And I think kind of the middle panel really sums it up, where you have a doctor telling the patient that you've done really well, and the patient is telling you that they're still struggling and they can't do things that they were used to able to do. So, we have retrospective data. We will be presenting prospective data at the European Stroke Organization conference. But, we know that more than half of patients after cerebral venous thrombosis will have some degree of functional impairment that is not well captured by the modified Rankin score. Issues with chronic headache, fatigue, cognition, and mood, and overall reduced quality of life. Many patients are not diagnosed correctly the first time around because cerebral venous thrombosis can have such an atypical onset and is not diagnosed well without vascular imaging, and patients may be traumatized due to a delayed diagnosis. Another thing that I think we don't ask about well as stroke neurologists is heavy menstrual bleeding, which can be a complication of anticoagulation that can affect the quality of life of our young women patients who are being treated with anticoagulation. And other things that I think have not been well studied are, systematic assessments of things like vision loss, secondary to increased intracranial pressure over time, and risks of late recurrent increased intracranial pressure. So just some things for consideration to bring you up to date. And sorry about the technical difficulties earlier, and looking forward to the discussion. Thanks very much.
Thank you so much, Talia, for an excellent talk regarding venous thrombosis. I'm sure we all had our fair share of patients. Going a bit to the question and answer, Dr. Nuran, you can take lead in this one.
Okay, thank you both, Dr. Talia and Dr. Buja. And I would like to start the first question with Dr. Bouja, and it's somewhat going to answer the question and the comment of Prof. Ali. So for those patients with low aspect and a large core, how you will counsel the patient or the family regarding the outcome, knowing that generally they don't do that well, even going for EBT. Yes, there is definitely a difference between the medical management and the EBT group, but what is your approach in counseling them?
Yes, it's probably, I'm glad you asked this question. It's the one question I wanted to say something more about out loud. And what I would say is that two things. Anytime we're making a treatment decision, we have to put it obviously in the context of that patient. And let's make the most extreme example. They have a poor quality of life. They have dementia. They have, significant disability. And now they come in with this stroke. Well, maybe this is actually more about that withdrawal of care. It's about focused on their comfort. But in somebody, for most people, and again, I don't want to say anything broad in general, but if you think about most people who come in without pre-stroke disability and are in this situation, and maybe without too many comorbidities that have already reduced their quality of life such that they personally do not value their quality of life. And those patients that are doing quite well, in other words, if you just think about it in terms of patients that they're going to have lifelong disability, 80, 90% of them, well, 20% will die, 70% will have lifelong disability. So if you can shift that number and bring more people to lower levels of disability, and for every 5 to 6 people you treat, you bring some patients to no disability, that's clearly cost effective and it's a better life for them. So that's what I think about it from that perspective, is like, what do they want based on how they were doing before their stroke and their current medical conditions? And then beyond that, it's about improving their situation. So, but it's a hard question, and I'm sure we could discuss it for much longer.
Yeah, but do you think that the evidence that we have till now is enough to be able to cross all the burden that we have, especially with the limitation of our resources? Maybe the resources here are different from USA and Canada and other places, but do you think they are enough?
So, yeah, I guess, you have higher treatment effects with smaller cores in terms of bringing patients back to a good outcome. In other words, fewer patients need to be treated to get a good outcome. So when you're having to prioritize, I think that's a consideration. But I think thinking also in the big picture about the fact that this lifelong disability is such a burden on society, what would ideally happen is a priority towards improving that situation. But for what is an extreme, like we do so well with heart attacks, and we don't even have these debates. And I think we need to shift the conversation in stroke, because these are really meaningful treatments. So I would say that, yes, if you have no choice, that's one thing, but hopefully pushing our regions, our countries, public health to prioritize impactful treatments is the way to go.
Okay, thank you so much. Okay, Athari.
Question for you, Thalia. What would be an alternative to anticoagulation in patients who have hemorrhagic venous thrombosis? And should thrombolysis and EVT be considered in venous thrombosis?
So again, I would say that just about everybody, even if they're presenting with a hemorrhage, should be treated with anticoagulation at the onset. Again, the mechanism of the bleeding is different than in primary hemorrhagic stroke. And again, if you're facilitating recanalization, you're reducing that impetus for further bleeding. There will be rare patients with, very, very large space-occupying hemorrhages that, you may need to do sort of immediate other treatments on, such as a decompressive hemicraniectomy. Again, there are certain situations where you just, have to look at, what is the fastest way that you can save someone's life. But in almost everyone, the presence of bleeding is not a contraindication to anticoagulation in the acute treatment of cerebral venous thrombosis.
Okay, Dr. Bouja again. So I'm really sorry, but I will ask you all the questions that you've already answered, so everyone can hear it. So for the ARMS trial, was MRI, CTP, or CTA done to exclude the LVOs, knowing that 10 or 15% they have a low NIH and large vessel occlusion. So what's your intake about this?
So my review of the literature, and I can tell you in PRISMs, it's about 10 to 15% of any occlusion, and maybe about half of those have a large vessel occlusion. And I think it remains to be seen how to handle these patients. We have the Tempo 2 trial going on. So that's one aspect I'll mention. We also have several trials going on for LVOs about whether we should take out that clot. And I can tell you the answer is not clear. It's not clear that we should be taking out the clots of patients with NIH stroke score 0 to 5, particularly non-disabling. But long story short, Aramis, I didn't see those results. I didn't see an exclusion based on that. I may have missed something, but to my knowledge, they did not screen out those patients in China. And I'll look forward to the paper and maybe more data there. So we'll see.
Okay, thank you so much.
Okay. Sally, I have a question from Maria, our colleague here. In routine practice, do you recommend repeating venous imaging before stopping anticoagulation? With partial recanalization, if it's such case found, do you still go ahead and stop?
Yeah, so again, how recanalization should shape our decisions about continuing anticoagulation, beyond kind of 6 to 12 months is not entirely clear. But I do like to have follow-up imaging for a few reasons. One, if you are continuing anticoagulation, yes, maybe be helpful. But it's also just nice to know what people's baseline is when you stop. Often, chronic headache is a big thing and patients are quite sensitive to symptoms. So when people present again, it's good just to know what their kind of most recent scan of their venous anatomy looks like in case there are issues. The other thing I would say is that, about 1 in 20 patients or so will develop complications like a dural AV fistula. So again, it's another reason just to have kind of good baseline neuroimaging in case there are issues that come up in the future.
Would you repeat imaging even after? Like if you stopped anticoagulation, would you repeat them after 3 months, 6 months?
No, what I generally do is I'll get a 3-month scan and often I'll get another one right before I stop anticoagulation. But unless there are new symptoms after that, I won't continue to do routine follow-up imaging.
Okay, so Dr. Pooja, again, what do you think about the blood pressure lowering post EBT? So Prof. Ali here, he was asking you, do you think that there is a correlation between the blood pressure and the degree of the recanalization? So if there is like a partial recanalization, do not lower the blood pressure, while if there is a complete recanalization, you can go with a lower reading.
It's a very good question. Yeah, because right now these trials have defined successful reperfusion as TICI 2B or 3, TICI 2B being more than 50% reperfusion of the vessels, whereas 3 is completely normal as far as we can tell. I know that the BEST 2 trial looked at this and they saw no evidence of a difference, but again, it's a very small trial with just 120 patients. I can tell you Enchanted didn't see any evidence and in fact suggestion of harm even for the TICI 3s in lowering that blood pressure. But they lowered it very low. They went less than 120. So we'll see what these future trials show. But right now, I don't know of any evidence that, at least empirically, that it is a good idea even to lower TICI 3 blood pressure. And I guess I'll just add that, with these large core data telling us that recanalization is helpful even when you see a hypodensity, it does make you wonder, like maybe that added blood flow is actually helpful in ways that we can't see on a macro level. But it's a very good question, and it's one I hope we get some better answers to soon.
So what is the target that you will write in your notes, let's say post clot retrieval, like a recommendation for the team to follow? And let's say that it's a complete recanalization.
Based on the current data that we have, we're allowing liberal hypertension, but keeping it below 180. We've moved back to that based on this study, and also, frankly, where I have to admit the fact that optimal BP has stopped for safety. makes me think do the same, but we'll see the full results of that soon.
Okay.
So yeah, bottom line is we're allowing low blood pressure now, which is so surprising. Actually, I think we all thought this was not going to be true, but I think what might have been happening is in our prospective data, when we were seeing patients that were doing well, they were having lower blood pressures because they were doing well, and it wasn't that actually lowering the blood pressure was really, was causal. It was more a side effect of doing well.
Okay.
You have a few for seizures and CBT, I can see here. So overall, would you prescribe prophylactic anti-epileptic in patients with venous thrombosis? And for those who present with seizure, how long will you actually treat them with anti-seizure?
Sure. So, about a third of patients with cerebral venous thrombosis will present with seizures acutely. I would not prescribe prophylactic anti-seizure medication because, people will be different and some people will have early seizures. And those are mainly the result of, parenchymal injury, patients who have any hemorrhage or parenchymal lesions, and patients with superior sagittal sinus involvement, probably just because of additional cortical vein involvement and irritation, are more likely to have seizures early on. I think where you want to consider treatment more aggressively is with later seizures. So seizures that are occurring after the 1 week mark, those patients are much more likely to have a recurrence, even if they're on therapeutic anti-seizure medications. About 10% of patients will go on to have, epilepsy. So, repeat seizures that are occurring later. And again, similar risk factors that you would expect, patients that have areas of encephalomalacia, patients that needed to have decompressive hemicraniectomy, patients that had hemorrhage, and patients that had seizures early on or were in status epilepticus at presentation. So, again, if you have a patient who has late seizures, I would be very reluctant to just take them off anti-seizure medication without a lot of counseling. But of course, because this is going to be, often a young cohort who may be of childbearing potential, it's important to manage with an expert related to epilepsy and pregnancy if you have one of those patients.
Okay, so Dr. Booja, again, I think we have like a million questions regarding clot retrieval in a large core. There are two things. Are you going to give TPA for those patients with a large core and the low aspect, or you will say that the evidence that we have is enough to skip this one? And do you think that the penumbra topography will affect your decision for going for clot retrieval in those patients or not?
Yeah, both really great questions. So regarding the penumbra topography, I think that is actually everyone's burning next question based on these data, and even the core topography. In other words, how much does the degree of hypodensity matter? Are there certain ways to measure within that core volume, patients that will or will not respond to additional thrombectomy? I can tell you multiple groups are doing studies around that, including mine. And I'm really looking forward to seeing them do that with the trials themselves and run through some more kind of advanced imaging interpretations that, we're not usually doing. Like, let's look at various Tmax levels. Let's look at textural analysis. There are many things we can look at in terms of that infarct to understand that. So I think that's the second question. The bottom line is, I don't know. And it's a question, that's the next important question. So the first question was,
yeah, will you give TPA for those cases with a large core and a low aspect? Or you will just skip it and go for EVT?
I'm really glad you asked that too, because I think that there can be some confusion. But bottom line is the evidence suggests that patients benefit from TPA even with low aspects. We've seen these in several analyses. So unless they have a clear large hypodensity, I always treat them with IV TPA or TNK now. If they're within, parameters for eligibility. And to the degree that we have these large core data, I haven't seen any evidence that the TPA patients are worse off or better off, from what we've seen in those subgroup analyses. And the bypass trials, even in the smaller cores, actually didn't show non-inferiority and maybe a hint of superiority of keeping thrombolysis on board. And then finally, I'll just add the fact that that maybe that thrombolysis again helps at the micro level with, you know, microthromboses, distal occlusions, and reocclusions. So I think I wouldn't skip it now based on everything we've seen. I see no evidence to support that.
Yeah, I think it's really tough question because knowing that even EVT will add a bit of a higher risk of bleeding, and we know that those with a low aspect have a higher bleeding risk with TPA. I'm really reluctant. Like when I think about it, I just think, why shall I give TPA? Maybe I will skip it and go for the EVT. Yeah, I know there is no right or wrong answer. It's really a tough decision.
I might push back a little bit and say, if you look at the Patel JAMA paper of reanalysis of the NINDS TPA trials, where they looked at subtle hypodensities and whether they modified treatment effect, they saw patients benefited even if they had subtle changes. So, you know, if there is this slight increased risk of bleeding, it's certainly not associated with a decreased risk of benefit, is the way I think about it. And that increased risk, I can't say, I think more than anything, when I see a low aspects, I first question the timing and just make sure that they're actually, because it's rare to see a 0 to 4 if they're really within 4.5 hours. So I guess that's another aspect to think about.
Yeah, thank you. Can we hear from Dr. Talia? What does she think about giving TPA in those patients? And from you also, Athari?
Yeah, I was curious about Dr. Talia's opinions as well.
So thrombolysis for cerebral venous thrombosis?
Or
No.
for acute ischemic stroke with low aspect.
Yeah, I mean, as you were talking, Dr. Patry, I was just wondering, so are you using, when you say kind of patients that don't have contraindications, are you kind of using that like 1/3 of the MCA infarct type rule when you're kind of considering where to stop for a patient that has infarct that looks like it's evolving, even though it's kind of within that, you know, typical window?
So the 1/3 rule that was used in the pivotal trials was based on clear dark hypotensity. It wasn't the subtle stuff. So I'm not using the 1/3 rule as far as the subtle stuff goes. I'm really just thinking about it. The subtle stuff is making me question the timing. But if I really believe it's early, then I am typically treating those patients. Yeah.
I'm probably usually biased in my opinion. If it's a left-sided stroke, I wouldn't, and I trust the timeline more. But if it was a right MCA, I'm not going to trust the last seen well, just because we've seen patients with huge early ischemic changes and their timeline just does not match their stroke with those ones. So probably right MCA, I'm not going to TPA. Left MCA, I feel more confident to TPA.
You know, that's a really interesting point. And one other thing that I have considered when there's questions, and I don't know how available it is, it's certainly not available as widely as we'd like, is I'm able, to my surprise, it's become very available at even my community hospitals, is to get an acute MRI. So I can get those pretty easily, even in the hospitals in the rural areas. So I'll do that, and I'll see that if it's flare negative and DWI positive, then that also gives me comfort.
We have a few more minutes, so we'll try to get as many questions as we can. For you, Thalia, we have a question here from Dr. Noor from Somalia, where she's describing seeing a lot of CVT in women, especially postpartum period. However, they cannot really do most of the workup for the etiology due to limited resources, so they empirically give warfarin. So for how long do you suggest to continue with warfarin? And she gave an example here for a young female who lost vision completely due to papilledema. So what do you suggest to help her with?
So I'll start with just the duration of anticoagulation, kind of in patients where you really don't think that there was any obvious precipitant apart from kind of the postpartum period. If you kind of treat it like a quote provoked venous thromboembolism, you may be able to anticoagulate for 3 months. You know, what I would do in a situation where you really do not have other resources to do a very extensive hypercoagulability workup is I would look for any ancillary evidence that this is just not quite a straightforward provoked event? Like, did the patient present with multiple simultaneous venous thromboembolic events? Like, did they have a CVT and a DVT or something like that? Is this a repeat instance for them? Have they had a previous history of venous thromboembolism, or do they have a suspicious family history? Or is there kind of anything about their presentation that makes you worry about things like antiphospholipid antibody syndrome or kind of anything like that? So I think, you'll really have to use your clinical acumen to look for red flags to determine if you think that there is a clear reason to continue with anticoagulation. And then with regards to papilledema, I'm very sorry. That's a terrible situation, but some degree of it may be reversible. What I would do is, if you can get this patient to a center where there are ophthalmologist experts who can do, or neurosurgeons who can do things like, if first of all, make sure that you've kind of tried conservative means like acetazolamide, and that you're not afraid to use the maximum dose in these patients. I don't know off the top of my head if it's safe for breastfeeding, so that's something that you would need to check. But first of all, to try to treat medically, and also to try to get this patient assessed by someone who can either put in a shunt or consider optic nerve fenestration to see if some degree of the visual loss may be reversible.
Okay. Dr. Booja, are you with us?
Yes, I'm back. Thank you.
Yeah, so this is the last question for you. If the patient had a successful thrombectomy and then he had a DVT in the next day, are you going to start the anticoagulation next day, or what you will do?
If they had thrombolysis on board, I'd like to see them 24 hours from thrombolysis. And so the next day is usually ends up being fine. With thrombectomy, I'm not as worried. But again, it also comes down to the size of the stroke for full dose anticoagulation. So there are a few kind of variables that come into play, but thrombectomy in and of itself wouldn't stop me if within a small infarct, be weighing the risks and benefits.
Yeah, totally agree with you. The size of the infarct will judge the timing.
That's really the main driver into my thought process. And what, we often do IVC filters.
Yeah, I think it's more tricky if you have a cardiac thrombus or a mechanical valve, and I think those are the tough cases really that we face.
Yeah, and that's where I'm more inclined to be aggressive, because we know those are really high risk, thromboembolic sources. So that's where I will probably be more aggressive and just weigh the, again, risk-benefit ratio. But no, we can answer there.
Okay, Athari, I think we only have 2 or 3 minutes.
Quick
or we
question.
are already done.
What is the relationship between anemia and CVT?
So we know that anemia is a risk factor for cerebral venous thrombosis. Exactly what the mechanism is not entirely clear, but particularly in children, it's a risk factor, and in adolescents. The other thing is that sub-study from the ACTION CVT trial recently showed that low hemoglobin at baseline is a predictor of worse outcomes, but it's really not clear to me, looking from the data, whether there may be some collinearity with things like malignancy, which we know is also associated with worse prognosis. So yeah, anemia is certainly a risk factor, and I would look for any treatable or reversible causes of anemia, of course.
Perfect. Nuran, if you have
No, I think we are done.
burning question, we can do. Otherwise, we will thank our speakers for tolerating our questions and actually for excellent talks today.
Thank you so much, Dr. Booja and Dr. Talia. And actually, my daughter, her name is Talia.
Oh, really?
Okay, it was great to have you all tonight with us, and great presentations and great discussion. And hopefully to see you
having us
in person.
Yes,
absolutely. Have a good night. Thank you so much.
Thank you, doctors.
Today. Thanks, everyone.